Today we have a case beyond the end-stage renal disease, recognizing Takayasu arthritis as a diagnostic challenge. We had a 38-year-old gentleman who was admitted with complaints of chest pain, which occurred actually during a period of dialysis from outside. And he was referred in view of this persistent chest pain. He had radiation of pain to left side of neck uh, associated with this chest pain. While taking the history in detail, he used to complain of pedal edema, which started around 4 to 5 months and was evaluated in an outside hospital where he was detected to have hypertension for the first time. And he was initiated on antihypertensive, which he could not recollect the names. That time he remembers that his creatinine was in the range of 2, but he does not had any complaints of hematuria or proteinuria. He had subsequent rising pattern of creatinine since last month, gradually rising from around 2 to 4 and then to 6. He says that the doctor reported him say there was some proteinuria also. Then he developed one episode of sudden onset of shortness of breathing, shortness of breath, and this time it was associated with accelerated hypertension. And his renal function was deranged. It was around in the range of 10, and was initiated on hemodialysis after insertion of a right IJV hemodialysis catheter. And he was referred here because of the chest pain. He also had complaints of jaw pain and right shoulder pain since few months, associated with complaints of fatigue on and off. On detailed examination, the right upper limb BP was in the range of 200 and 200, 120. Left upper limb was around 190, 120. Left lower limb was again in the range of 200, 100. Pulse, it was almost all the peripheral pulses were equal in volume as well as in rhythm. And his fundus examination was done, which actually showed a grade 4 hypertensive retinopathy, but no features of any papillary edema. Apart from this, all other peripheral pulses, no bruit, no renal artery bruit, I couldn't appreciate in him. And paraben also no organomegaly was visible, was felt. Subsequently, the investigations were done, and he showed his anemia after one episode of dialysis, which was done from the outside hospital with potassium of 5.2. And the urine examination actually showed a bit of microscopic, say 2 to 3 RBC with proteinuria 2 plus, and significant urine PCR ratio of around 10.4. Apart from that, other labs were almost within normal limits. As he had a significant chest pain, which was radiating to the neck, his initial cardiology evaluation was carried out. CKMB value of around 10. There were features of LB, of coronary syndrome was there, associated with chest pain. So a moderate stenosis of coronaries were seen, and here they suggested a medical management for him. We subsequently started him with multiple antihypertensives, antiplatelets, and diuretics, and hemodialysis sessions were also carried out. He was initiated on nifedipine extended-release tablets around 90 milligram per day, metoprolol 100 milligram per day, hydrolysin around 150 milligram per day, clonidine around 600 milligram per day, minoxidil 5 milligram was started as the BP was not getting controlled. He was before that he was initiated on telmisartan, aldactone, and torsemide. So all this was characteristic of a refractory hypertension. So if hypertension, a refractory one, just due to CKD, apparently showing partial loss of CMD with increased echoes, with very minimal size difference between left kidney and right kidney. In view of this refractory hypertension in male, with being carried out as he was unable to hold breath because he was always complaining of chest pain and neck pain, unable to hold breath. And CT renal angiogram actually showed from the around 7 to 8 millimeter from the ostium, this red arrow from the ostium, this left main renal artery was showing around 50%. And in this right side, this is the posterior segmental artery. This is the anterior and posterior segment. Here there's a luminal narrowing, which probably suggestive of a stenosis in this posterior segment also. CT iotography next day. And this actually demonstrated an aortic, this is actually probably a collection seen just in the plaque as per the radiologist report. And also in the infrarenal, as well in the abdominal aorta, we could see there was significant thickening. So there was diffuse wall thickening in the descending thoracic abdominal aorta also, apart from the main renal artery, as well as segmental renal artery findings, which we have already described with the renal angio. So the radiologist could say this is provisionally a Takayasu type 3 aortitis. As we see this Takayasu classification, I think this again corresponds. We came to conclusion that this could be probably type 3 Takayasu arteritis, as there was definitely evidence of aortitis with descending thoracic aorta, abdominal aorta, and renal aorta. But still, are we missing out something? We wanted to search out the causes for aortitis, including whether it could be a giant cell arteritis, arteritis, any other autoimmune conditions, including systemic lupus erythematosus, which can present in any way, or be any other disorders, especially IgG4, which can actually have presentations with typical aortitis without other organ involvement. Again, we continued for other any RBCs in the urine. We went ahead with an ANA profile, which was negative. Anti-DSTNA was negative. Anti-MPU, anti-PR3 was negative. Anti-beta beta microglobulin, anti-cardiolipin antibody were negative. As we say, we have so many case reports of aortitis presenting with IgG4. We checked serum IgG4 levels, which were negative. RF factor was also negative. Still difficult to explain the proteinuria in his MHC sessions, and we're asking for possibility of renal transplant if he is being planned for a regular dialysis. So definitely we were also curious of finding the native kidney disease and explained all possible risk of bleeding and went ahead with renal biopsy, which is ultrasound guided. And that actually showed, as we see in the picture, there was marked glomerulosclerosis, and almost 80% of the, more than 80% globally sclerosed, and we could all change. So we could anyway confirm left renal artery stenosis with the main segment, 50%, the posterior segment was critically occluded. There was a Takayasu arteritis contributing to a renovascular hypertension. And the chronic kidney disease could it possibly be a hypertensive nephrosclerosis, as we see in the biopsy picture. And at this point of time, it's already on maintenance hemodialysis and reached the point of ESRD. Subsequently, he was treated with steroids and advanced anti-TNF agent, especially adalimumab or infliximab from the rheumatology side. But he couldn't afford adalimumab because it was around 25,000 per injection, as well as infliximab, which cost around 40,000 per injection. And simultaneously started on steroids around 1 mg per kg, around not exactly 1 mg. He started initially, those 60 mg was started, he couldn't tolerate, slightly reduced to a dose of 50 mg per day, and then gradually tapered to a dose of around 30 mg later. And MMF was initially started by 250 milligram BD and then increased to a dose of 500 mg BD subsequently. After a few months of follow-up, he's on even after dialysis, and he definitely requires a maintenance hemodialysis. And his constitutional symptoms, including the neck pain, jaw pain, has subsequently reduced. His ESR after around 5 months of suppression gradually reduced around 20%. So we do have plans like, say, he is having around, he was initially on 7 drugs, and now he's BP bit control, overall could get a BP control, have options like renal artery embolization or renal artery angioplasty, because he is on multiple drugs and should we go ahead with that. And he always asks whether that renal transplant is still possible in him. We still are in doubt. I think narrowing, especially the aorta and the proximal branches, including the subclavian, which is the most common ones usually seen in typical Takayasu. But definitely we had seen many case reports where there are atypical presentations with a type 3 aortitis. And this nephrotic range proteinuria still, I don't know, even with acute illness, it might have been precipitated, but still to explain